requesting that it gets updated. The components of a 504, basically it's a paper document that will travel all the way from preschool all the way up, that comprises of a lot of different variables. So it's different for each and every child. It's very individualized. It has medical documentation within it that will allow your child to come to school a little bit late, because we all know that having CF, we've got to get up super early and get our kids to school, and there's a lot that it entails. So, you know, if you need that extra hour, if you need extra lunch, you know, snacks at school, allowing them to take their enzymes, you know, there could be some issues with gym class, a ton of different things that it can help you with. And like I said, it's individualized for each child. In order to get a 504, it's actually a really simple thing. A lot of parents get overwhelmed, you know, especially when you're first starting out in school and this is your first time and you have a CF kid and you're just really overwhelmed in general. Basically, it just starts with a line of communication. One, you can talk to your social worker about that. They can also help you along the way. Next is just contacting your school to request a 504 plan. It's really as simple as that. They have people within the system that are designated to help with that. The school principal, teachers, etc. What I tell my patients when they come to see me and they have questions about 504s is that start keeping a notebook. Write down things that affect your child on a daily basis, especially when they're little. What's going to affect them when they go to preschool or kindergarten or even in elementary school? You know, what about their enzymes they have to take every day? What about the embarrassment of bathrooms? You know, because that is an issue for some kids. So we can make that accommodation in those 504 plans. I don't want to keep this too long because I think that the 504s are really individualized. So I encourage you to you can come talk to me today and I can give you some tips and some pointers. And Corinne, she couldn't make it today, but she is going to be getting a little teary-eyed here. She's going to be the social worker for the clinic. So she's going to be able to help you out. She's going to be a great resource and a tool for you guys. She works with the pediatrics over at the hospital, so she has a lot of resources from over there as well. Do you guys have any questions? Because I like to get that sort of thing from parents so that I can elaborate more. Do you guys have anything? Go ahead.
So you had mentioned that you go to the school and ask them to create a 504 plan. Is it also an option to use the tools that are back here? Like, can we create it ourselves and take them as well? Or is it a process to start with the school?
Well, the tools that I have, yes, I would suggest that you start with the school, but those tools that I have a ton of 504 information on that back table. Amazing resources. But I suggest that you call the school, at least to make them aware. You don't want to, blindside them with, oh, hey, here's 5,000 pieces of paper, and my kid has CF. So I think it would be best to call the school, let them know my child has CF, I want to start a 504, but I already have a template for you, so let's sit down and talk about this. One of the things I find with parents is sometimes we can get demanding because it's our child and they're super important and we love them and we want to take care of them. And sometimes when you get into this situation with the school and you want something and you're demanding and the school wants something and you kind of butt heads. So I advise everyone to be open-minded. So talking to the school and keeping that open communication is a very good start. Anybody else? No? Okay, that makes it really easy. But like I said, on the very back table, there is a ton of resources. Utilize these all the way from preschool for your child who is of college age. There's letters, sample letters, there's sample 504 plans, and there's also a really good tool that I find for the younger kids. It's a sample booklet that a parent made that talks about their child in CF. So they basically went in to the teacher and handed them the booklet, so the teacher understood exactly what it was. So I find that like an excellent tool. So with that, I loved being a part of the clinic. So you all mean tremendous things to me, and you have made me a better social worker. So with that, come talk to me. I'll be back somewhere over there. So, and thank you, and hopefully this school year won't be as treacherous, and I'll get you through it. So, all right, thank you.
Thank you, Laura, and thank you for your time with us. We appreciate it. Corinne is going to be kind of a temporary, and they have gotten approval to get a social worker that will be full-time. Laura's already been our full-time social worker. The difference is that we'll have a social worker that will actually be available 5 days a week, where before we were kind of, Laura was at the hospital and with us and wasn't always available all the time, and because that's how the position was set up. But they're understanding that we need more, not only us, but some of the other clinics also. And I know a lot of you see Dr. Abu Harbor, the PEDS GI group. And so the social worker will be kind of available in a lot of different clinics, and especially for some of you that see other specialists, I think it'll be a really nice transition that you'll always, have someone available, and it'll be the same person, and they'll get to know you really well. So again, thank you. So now we have the highlight of my day is having Dr. McCarthy come up and speak. We appreciate it, and he's such a good teacher, and we all love to learn from him. So come on up, Dr. McCarthy. He needs no introduction.
Okay, while Tanner's getting some slides up, I wanted to really, first of all, thank everybody who's here and congratulate everybody who's here. I just think this is an amazing event, and so many things. I want to thank our team, Kendra, and everybody else put so much effort into these events, and I think that we and our patients are extremely lucky to have that kind of dedication. For those of you who are our families or patients, I think that I have a pretty strong feeling, and the rest of our medical team have a pretty strong feeling of how difficult it is just to get through a day and a week with a patient with cystic fibrosis, and to have you actually come out on a Saturday when you could be doing something different. I think it's really a compliment and something that you really should be congratulated for. Can everybody hear me, by the way? Is it loud enough? Okay. Another theme that's already been sort of introduced, I want to also thank Laura for all the tremendous help that she's had and the devotion that she's put into this clinic. Transitions. We're very sorry to see Laura leaving. I'm very happy to welcome Dr. Chavez, who you hopefully will all be seeing. We now have 3 doctors. I'm really happy about that. Come up and introduce yourselves. So again, we're trying to make this a very informal event today. And the next thing I wanted to say was that there's by the way, these slides, what I have here, you can kind of ignore. I had to put something up. But I gave Graham Brown's presentation for the pediatric community here at Providence a couple of months ago. And then I combed through just a couple of slides from this, and I'm going to be flipping and probably losing my place and so on. I'll apologize ahead of time. But that's where these slides come. And as I kind of get into this, this talk makes me a little bit nervous, more than a little bit nervous, because there's such a wide, I don't know what you all want to hear, I don't know exactly what I want to say, there's a very wide range of knowledge and experience in this room. And there's some people in this room, in addition to the medical staff, aside from the medical staff, who know more about what I'm going to talk about than I do. I'm not going to mention any names or look in any particular direction, but there's some amazing resources in your CF community and families. And then I suspect at the other end of the spectrum, there are people that this will be brand new information for. There will be people kind of in between who've heard this stuff before but didn't quite get it, or got it and forgot it. That's what I do. Or were preoccupied with other stuff, such as their own health at the time we talked about it in clinic. And so this, it's hard to know exactly where to put the message. But I do feel, that my assignment is to talk about what's new and what's going to be available for us to use as treatments, particularly in the very near future. But I always feel like it's important for not only those of us who treat patients to understand, we're not just writing out a prescription, we're hopefully kind of understanding, well, what's the point of this, how does it work, who is it good for, who is it not good for, and so on and so forth. And I think it's important for patients and families to know that too. And so I'm going to present a little bit of basic scientific information, and please interrupt me and I'll try to explain it, and please interrupt me if it doesn't make any sense, or move me along if it's boring you, and we'll just kind of go through a couple of things. Okay, so first thing is, let me go down, and I just do this with the arrows, right? Kind of to put into perspective new treatments, it's important to kind of understand where we are, with our current treatments and where we've been with our prior treatments. And this is a graph of changes, basically improvements. I think everybody's quite aware, who's been involved in cystic fibrosis at all, that the prognosis of cystic fibrosis has just tremendously skyrocketed over the years. The improvement in this is the graph that goes from the 1950s are kind of a landmark era for cystic fibrosis. It's sort of the beginning of the modern era of cystic fibrosis, when the sweat test was invented and people really started to have a little bit of understanding about what would be the connection between having something wrong with digestion and having something wrong with your lungs, and so on and so forth. So it's sort of the beginning of scientific discovery, really not quite true, but basically it was sort of the beginning of the modern era. And when that, in 1950, the prognosis for a baby born with cystic fibrosis was absolutely terrible. Now, it turns out that one of the many things that's been discovered is that it probably wasn't really that terrible, but there were a lot of patients who had mild cystic fibrosis who simply weren't diagnosed. That was not understood to be cystic fibrosis. So that's buried in these statistics too. There's improvement in how people have done, and also there are people who've always done well, but we just didn't know the NCF. And then over time, there has been a tremendous improvement. And let's see, from last year's registry, look at the very bottom right hand, I already forgot where my pointer was, but anyway, the now median lifespan, and that's the type of average that means half the people will not survive to that age and half the people will survive beyond that age. And many of you may be aware that we have one gentleman in our clinic who joined our clinic as a patient 2 or 3 years ago who is, I think, 62. So anyway, this is the kind of improvement that we've seen. And these kinds of improvements have come with breakthroughs to an extent, medications such as Dornase or Pulmozyme, which I think most people here probably think of as old hat, but I have been in practice, unfortunately, long enough to remember before Dornase existed, and that was like this incredible breakthrough at the time. But as compared to some of the amazing things that have already been hinted at today, and I'll talk about a little bit, they really are just sort of maybe a little bit boring and a little bit sort of routine types of therapy aimed at the problems that are encountered in cystic fibrosis. And now we're on the horizon of seeing incredible, true breakthroughs. But a lot of the improvement has come from just more careful attention to plain old-fashioned things such as treating infection, improvements in the availability of antibiotics and types of airway clearance, improvements in nutrition, improvements in mental health, and all the sorts of things that we try to do. So that's kind of where we are. And let's see here. Sorry about that. Our clinic kind of, as a result of the improvement in prognosis for cystic fibrosis, lo and behold, a lot of our patients are becoming adults. And that's very exciting. And basically, right around half of cystic fibrosis patients in the United States are 18 and older. And our clinic's pretty similar. I think these statistics were maybe from a year or two ago. But basically, we have a pretty representative clinic. And because we're a clinic that takes care of adults and children, we have these kinds of statistics. There are special kind of considerations and concerns that we run into, and this is something that comes up in conversation frequently, anywhere from in our exam rooms to the National Foundation and national committees and so on. There are a lot of questions and debates about who are the best medical care team providers to take care of patients who have what used to be a childhood disease, but who are now adults, because adults are different from children and have different kinds of characteristics and different kinds of concerns. And I don't want to go through all that, but I think that I'm sure all of you have thought of these things too. But we, in talking about the committee that is trying to make us do a better job, and I think that's a really wonderful to get input, because we don't find we just sort of see patients. And I personally, and I think all of us, welcome input from all of you. And one of the specific things might be dealing with adult issues. So, okay, so that's sort of an introduction. Now, here comes the science. Everybody ready? Let's see. Okay, so, yeah, I think I can explain most of this. So, what is cystic fibrosis? Okay, so cystic fibrosis, everybody knows, it's a genetic condition, and it's the type. There are different kinds of genetic patterns that can exist for different characteristics, whether it's eye color or whether it's diseases or whatever. And cystic fibrosis is the classical type of pattern where you have to get one gene from your mother, one gene from your father, and if you just get one gene from your mother or father and not the other, then you will not have cystic fibrosis. So you have to have two abnormal genes. I think everybody in this room knows that very well. Okay, so there is the setup for a patient who is born with cystic fibrosis is that they have an abnormal gene, or have two abnormal genes, a set of mutations. And genes are a kind of a blueprint that occurs inside the cells of all of our cells in our body that then are used like a blueprint to make some kind of a building or some kind of a product. And the product in cystic fibrosis is called CFTR. And specifically, now I should get the pointer out and see if this, boy, that doesn't show up. Anyway, so what is CFTR? Well, basically, what work the CFTR, or the gene product, what is built from that blueprint, is called a chloride channel. And what this is, and now let's just imagine just the lung situation, because as you know, there are problems with digestion, there are often problems with liver, other parts of the body. Let's just talk about the lungs. So now imagine, we have our tracheobronchial tree where the airways bring air down into our lungs, and they branch into tinier branches, and eventually into the lung sacs or alveoli where oxygen and carbon dioxide are exchanged. So now this, let's just say, is a representative bronchial tube right along here, this blue passageway. And what is happening is that there are cells right on the surface of those bronchial tubes. And these cells have transport of various chemicals that, and basic bottom line, I'll quit hemming and hawing and get right to it. There is a type of a channel called the chloride channel, and this is what is involved in cystic fibrosis, either in the normal situation or in the cystic fibrosis situation. And this is the cell, this is the bronchial tube here. And in the normal situation, chloride is is transported out of the cell into the bronchial tube. And there is sodium out there, so you have sodium chloride or salt, and sodium chloride draws water out into the bronchial tube, just like pouring salt on a slug when you draw the water out. So, in the normal situation, you have plenty of chloride that's leaving the cell and going out into the bronchial tubes, and you already have sodium out there, and this serves to pull water out, and you get nice, thin, hydrated secretions. So, you have very thin, and you're not even aware of having secretions because there's not very many secretions, and they're very thin, and this allows clearance of any debris or bacteria or anything that might get into the airway. Now, in the cystic fibrosis situation, this channel is abnormal for one reason or another, and in one way or another. And what happens is the chloride gets stuck inside the cell, and when the chloride gets stuck inside the cell, there's nothing to pull water out, and so you get very dried secretions in your bronchial tubes, and that's the dried, thickened secretions that everybody here is aware of. And those dried, thickened secretions then trap bacteria and sets up a whole set of problems that we run into in cystic fibrosis. Now, any question about that? And please interrupt me, don't be embarrassing, or I think I kind of mumbled through that a little bit. But anyway, so that's the problem. Because you have these dry, thickened secretions here in the cystic fibrosis situation, you end up with obstruction of your bronchial tubes. And this is a microscope picture, but this is a bronchial tube here. And in the normal situation, there basically shouldn't be anything in here but air. But here is a big bunch of thickened secretions, and that's what's going on inside the lungs of somebody who has cystic fibrosis. Because you have those thickened secretions in there, bacteria get trapped, that's an infection. Next thing that happens is when you have an infection in any part of your body, but we're talking about the lungs, a very complicated process starts to occur called inflammation. And people always ask, what's inflammation? When I was in medical school, I remember we had a whole course on inflammation. And the very first day, and none of us had any idea of what it was. And, you know, someone said, what's inflammation? And they said, well, okay, come to class the next, 3 months, 5 days a week, and you'll find out. But inflammation basically is a very complex process in the body that has many purposes. But in terms of what we're talking about, the purpose is to fight infection. So there's white blood cells that come in and gobble up bacteria. There are antibodies that come in and help with the process. And there's a whole bunch of other stuff in it. It's extremely complex. You have to take the course. One of the things that people learned about cystic fibrosis many, many years ago, this is before the gene was discovered and whatnot, is that the inflammatory process in the lungs is kind of a double-edged sword. And it's not only helpful, it's essential for fighting these infections. And if you don't have inflammation in your lungs, you will not be able to successfully fight the infection. You get horrible pneumonias and whatnot. But as part of the inflammatory process, it's like a war zone. And all sorts of things get thrown off, and you get, just as in a war zone, you get innocent bystander damage. And that is a medical term. They use that term in discussing these things. So there's chemicals that are being released, and again, antibodies and white blood cells and all this stuff. And in the process, you're fighting infection and killing some bacteria, but you're also causing some damage, getting some damage caused to your lungs because of innocent bystander damage. And this is one of the main goals that we have in treating cystic fibrosis, is to, number one, kill bugs, and number two, decrease inflammation so that you can still kill bugs. So you want to totally decrease it, because you want to decrease enough you won't get damage. Okay, and if you get damage, the specific kind of damage we get in the lungs is called bronchiectasis, and I'll go into detail on that. Okay, so, that's louder. Again, tell me if I'm not speaking loud enough. Another different pictorial way of saying the same thing that I just said is that you, it's called a vicious cycle. So you have thickened secretions cause obstruction, and that causes infection to be invited in. That causes inflammation to occur, which is good and bad. part of the process of inflammation, one of the bad things about it, is it further thickens the secretions, and then you get more obstruction, more of it, and then blah, blah, blah. So that is going on in the lungs. Now, okay. I don't think I need to really mention to you, this is a cartoon of various things, but basically, again, this is what we're talking about. This particular chloride channel in the cell that's lining the bronchial tubes is in one way or another abnormal and has trouble, and therefore the chloride gets stuck inside the cell rather than coming out into the bronchial tube to the water and make nice excretion. Okay, so that's the summary. Now, things got fancier and more complicated and fancier and very cool and as research moved along, because what they found in 1989 was when they found the cystic fibrosis gene. That's another hallmark of like 1950. And they found one gene, known as the delta F508 gene, which a lot of people will recognize as a common cystic fibrosis gene. And then all of a sudden they found another gene, and all of a sudden they found another gene, and pretty soon it was like, wow, this is bizarre. There's so many different mutations that can lead to cystic fibrosis. Combined from two, one from each parent, and it turns out there's about 2,000 different mutations. And that was, first of all, it was very interesting because apparently there are not a lot of genetic conditions that have that many mutations. Number two, it was first very exciting because they said, oh, this cool, this cool. And all of a sudden it became kind of a negative because, well, what are we going to do with all this information? I mean, if there's one gene, maybe we can do something about it. But if there's 2,000 genes, what can we possibly do? And early after they started discovering all these things, and this is one of the reasons that we want all our patients to have their genes analyzed, and I think all of ours, or virtually all of ours are, one of the things they started to do was to be able to divide the 2,000 different mutations into types. And this is very interesting and very complicated, and I think I can explain it again. I hope I can. But don't be scared off by the complexity of this slide. Basically, they've divided the types of genetic mutations that can occur in cystic fibrosis into 5 different classes. There may be a 6th class, which is kind of a mix of some of the others. But let me just very briefly kind of explain. So, in the normal situation, here is the I can barely see this, but anyway, here's the concept. So you have the blueprint down here, or the gene itself. The blueprint makes a building, which is the CFTR, or chloride channel, and that travels up. This is the inside of that cell that I showed you. And it gets to the edge of the cell. Here's the bronchial tube along here. Okay, so it gets up here, and this is a picture of a chloride channel. And the channel is in the middle, and chloride can go through it, and so on and so forth. Everything's working perfectly. Okay. Now, in one kind, and here we get into the mutations. So this is normal. These are abnormal or mutations. Here we get into mutations, and in this situation, the gene is such an amazingly, what do we say? It's just a very, very abnormal thing that's inserted or left out of the gene, such that no building is made at all. The blueprint is gobbledygook, and you can't even make a building. So, lo and behold, there's no chloride channel at all. That's one type of cystic fibrosis that can occur. In this situation, the blueprint's fairly abnormal, but a building is made, but the building's fairly ugly or non-functional. And it is recognized by various mechanisms inside the cell as being a very abnormal CFTR, or chloride channel. And it is ripped apart or degraded, and therefore there's nothing up here. So again, there's no chloride channel at all. In this situation, again, all of these have abnormal blueprints. So a building is made. When you first glance at the building, it looks pretty normal. Okay, so it is allowed to go on up here, and there's a chloride channel up here. But because of some very specific characteristics of it, chloride can't get through it. So there's a chloride channel, but it's not open. This one is kind of a variation of that one, kind of similar thing going on. And then this one has sort of a combination of, to some extent, the building is recognized as abnormal and ripped apart, but some of it goes up here, and then it is, again, not a functional channel. So those are the kinds of things that can occur. And when people first started understanding this, and as you might imagine, it took very, very complicated science to sort through this, we all sort of looked, well, that's interesting, but what in the heck, what does it mean, and what can be made out of it? It turns out this becomes very practical information, because if you know what's going on inside the cell, then you can target therapies, you can invent new chemicals or find chemicals that already exist that counteract the abnormality. And so, for example, you can invent something that protects this building from being ripped apart, and it is allowed to travel up here, and then you can start to worry about whether chloride can transmit through it or not. In this situation, you have to invent a different chemical that the purpose is not to protect the building from degradation because it's protected, and then they have to worry about that. But it doesn't work, and so you have to figure some chemical that will open it, so on and so forth. So it becomes very, instead of very theoretical and weird, like, well, that's great, but what does it mean? It becomes extremely practical, and that's really what we're talking about today, beginning with Kaleido three years ago. Okay, so that's the basic science. Now I'm just going to talk, I'm just going to go through a few things, and I will talk mainly about the new medications, but a couple of other things just to mention. One of the things, and this is not something that's newly, that there's anything that we are expecting to come on the market in the next year or probably in the next 5 years or so, but you can never predict. But one of the things, and you can either look at this slide or this almost makes it more complicated, so let me just tell you about it. It was recognized many years ago when they started to find the different gene mutations, that even though cystic fibrosis is caused by gene mutations, there's an unpredictability about how significant the problems are going to be. Some people with the same exact mutation have very mild cystic fibrosis, and then the next person with the same exact mutation, not a different mutation, but the same exact mutation, has very severe cystic fibrosis. And that's always been a puzzle from very early in this kind of research, starting in 1989. You could explain it by, well, some people grow up in a slightly different environment, they're smoking, or there's more kids in the family, so more exposure to colds, or all these different kinds of explanations you come up with. But it's more complicated than just the different environment. And what the scientists have come up with is a pretty strong conviction. I mean, it's pretty well recognized now that everybody, there's so many, I mean, CF and CFTR, the chloride channel, is just one gene. There's all these other genes that we have for all sorts of other characteristics. And it appears that there are other genes having nothing to do with chloride channel and having nothing really to do with cystic fibrosis that will have some kind of an influence on how your health is if you have cystic fibrosis. And there are some genes, and we don't know what they are yet, which will make your cystic fibrosis milder, even though you may even have a so-called severe form of cystic fibrosis. And then there are some genes or mutations in genes which will make your cystic fibrosis more severe. And there's a lot of research being done on this. It hasn't really paid off yet, but we hope that it will. And we're going to be looking out, in the future and saying, hey, what are they coming up with in terms of modifier genes and understanding what this is about. Okay. Same slide. So now I'm going to get into some practical things, and I'm not going to we can talk about each of these things in terms of many types of treatments that we do now or treatments that we anticipate in the future. But I just am going to mention a very couple of very few examples of some things. In terms of inflammation, there's all sorts of things we've tried through the years for dampening down inflammation a little bit so you don't have the innocent bystander damage. A couple of things that are sort of lurking on the horizon and have been lurking on the horizon for many years. forget about the slide. There's a couple of products in particular and types of products. One is a medication called alpha-1 antitrypsin. And if you look on websites and so on, you may find something about that. Alpha-1 antitrypsin is there's a medication that is for an entirely different genetic condition, which can also, by the way, cause lung damage. It's a little bit different than cystic fibrosis lung damage. But it's the medication that has been available for that disease for many, and it affects mainly young adults. It usually doesn't affect children, even though you're born with it. That medication could also, because it's on the market, could also be used to treat other conditions. And bottom line is, alpha-1 antitrypsin is a medication that has been shown in experiments to cut down a bit on the type of inflammation and therefore the type of damage to the lungs that inflammation causes. And there are some trials coming along looking more strongly at alpha-1 antitrypsin, and it may become another treatment that we use in treating cystic fibrosis patients. And then everybody's familiar with antioxidants. You can get them at the huckleberries. There's all kinds of natural antioxidants and so on and so forth. But oxidation, what are antioxidants? I'm sure most people that take antioxidants have no idea what antioxidants are or what oxidation is. Basically, oxidation is one of the many, many pieces of the complex process that we learned about way back when, and I forgot about in my medical school class on inflammation. So oxidation is part of the inflammatory process, and when it gets triggered, you then can kill bacteria with that process. But it also causes damage to lungs. So antioxidants, at least theoretically, are very helpful for people who have inflammation going on in their lungs, and various kinds of antioxidants are being looked at and have been looked at for many years, and some of them may make it to market in terms of an actually recommended drug for cystic fibrosis. Okay, enough on inflammation. Now we talk about infection. And what's else I was trying to get in my information? Antibiotics. Most people who have cystic fibrosis or have somebody in their family with cystic fibrosis are very familiar with inhaled antibiotics. Inhaled antibiotics are absolutely fantastic in a lot of ways for many different reasons. One is that some of the inhaled antibiotics that we use give us a whole new set of antibiotics that would not be there. There's nothing available in terms of a pill, maybe not even something available in terms of an IV drug. So it's a whole new approach to treating. And then, of course, there's all sorts of advantages. When you inhale an antibiotic, you basically don't absorb it to any significant extent, and therefore the chance of getting side effects and